Hello, and welcome to Your Health Matters. I'm your host, Dr. Peter Hogenkamp, and today we're going to be discussing exercise as treatment for various joint injuries. For those of you who've tuned into the program before, you'll know that I discuss exercise quite often on the show. We've discussed exercise as a treatment for weight loss, for high blood pressure, for mental health problems. Today, we're going to be discussing exercise as a way to treat joint injuries. To this end, I have the great pleasure of welcoming my colleague and friend, Tyler White. Tyler is a certified athletic trainer who practices locally. I've had the good fortune of working with Tyler for many years, and I'm very excited to have him on the program. Of note, this idea kind of came about several weeks ago when Tyler actually sent me a couple of videos to help me with a knee problem I was having, and I realized that how good he how much benefit I gained from the video he sent me, and I thought to myself, if I can benefit from this, then you can too as the viewer, and I hope that a lot of you will actually feel better as a consequence of our work here today. So I wanted to start off with a couple of stories. I love to tell stories. I believe in the power of the narrative. And the first story comes from when I first moved to Vermont 23 or 4 years ago. I was working out in Castleton as a family doctor then, and I had this older gentleman come in with back pain. And he comes in with back pain. He had a significant back injury, and I wrote a number of prescriptions, which at that point in time I handed to him with paper, and he kind of looks down at me, and he's like, what are these? I says, well, those are medications. He's like, Doc, I have a musculoskeletal problem. I need a musculoskeletal solution to this. He goes, what are these pills are going to do? Well, of course, at that point in time, just out of residency, I thought I knew what I was doing. And I insisted he take these medications. He comes back a week later, and he might be a little bit better. And I finally listened to him. I sent him to a physical therapist. And when he came back to see me 2 or 3 weeks after that, his back problem was completely solved. And I learned at that point 2 things. One was that just like they had told me in medical school, patients will oftentimes give you the answer if you just listen to them. And number 2, I learned that when you have a musculoskeletal issue, you need to have a musculoskeletal solution. The second story is kind of just confirmation of that. I had a tennis elbow problem, which is one of the things we're going to discuss today. And I actually had all kinds of treatment for that tennis elbow problem. I had a steroid injection. I had platelet-rich plasma injections. I was actually thinking about having surgery for that problem, which we rarely see with tennis elbow. And I got some excellent advice from one of Tyler's colleagues about how to treat it with exercise. And I was able to heal up that tendon problem within a month. It flares up every now and again, and I'm able to use those exercises again. And the problem simply, I can manage the problem. And that's one of the things I like about these, is that the patient can really use these things as a tool to manage their own problem. All right, so with that as said as introduction, we're going to talk about 4 common problems. One is knee arthritis. 2 would be a rotator cuff impingement. The 3rd would be tennis elbow, as I mentioned, and the 4th would be an Achilles tendinosis. So Tyler, let's start off with a knee osteoarthritis. Tell us what the issue is, who might get the issue, and how they might present.
Thanks, Peter. The knee osteoarthritis often comes in to an individual that has a little more advanced in age, we'll call it. I call it an advanced in age athlete. We don't want to be too harsh on anybody, but it's probably somebody that's done a lot of running in their life, played some sports, maybe some football or basketball when they were younger, or even people that have worked hard their whole life in a physical manual labor job, so a construction worker, somebody that's on their feet a lot, something like that. And so what it really is kind of the wearing away of the joint cartilage, and so you can kind of see it on x-ray where there's joint space closing. So this is something that you get pain with. Not often, or sometimes you'll have pain in one knee, same amount of joint closing on both knees, but you'll have pain in one knee and not the other. And so what we're trying to do with the exercise is create what we call a cocontraction. You'll hear me say cocontraction a lot, and that's that one side of the joint muscle firing and the other to stabilize the joint. And so these co-contractions can really help reduce the pain at the knee. It's something that's worked time and time again to prolong people's athletic lifestyles.
Yeah, I was going to make 2 points to what you said, and that is, number one is, oftentimes I've seen patients with bothersome knees, and we get x-rays, and one x-ray will look a lot worse than the other, and the patient will tell me, well, geez, I have more pain in this side. And that's something I've learned again and again, and that is that sometimes it's difficult to tell how much pain somebody is going to have just from an x-ray.
Yeah, there's something, working with some physios from Europe, actually, they taught me the term, treat the man, not the scan. And so the scan can show you one thing.
I love that.
They can show you.
I'm using that.
Feel free to use it. It's not mine. It's stolen material. But I love the term because it's the symptoms of the athlete, of the person, more than it is what the scan tells you.
The other thing I was going to say is, and I oftentimes tell patients this, especially when we're talking about knee arthritis, when I send them to physiotherapy, and they'll say, well, wait a minute, if I've degraded the cartilage in my joint, how am I going to improve this situation other than by getting a knee replacement? And what I tell them is that the integrity of a joint is not only the joint, but it's the surrounding tendons and surrounding muscles.
Correct.
And then if you're getting the muscles to be stronger, if you're getting that knee to move more properly, it's going to help their pain.
Very, very true. And the benefit that we're really getting from this, from doing these exercises prior, even if there's someone that's a real good candidate for a total joint replacement, the exercises that you do prior to the surgery is going to help you recover after your surgery. There's a lot of research on it that shows, and specifically in the quadriceps, the more strength you can get in the quadriceps prior to surgery, the better result you're going to have. The big focus here is going to be co-contraction and stabilizing the knee. So exercise number one is going to be a true co-contraction, which is the quadriceps and the hamstring working together. So I'm going to use my heel to push into the ground. Straight down is my pressure. I don't go anywhere. It's what we call an isometric contraction. So it's the muscles firing, but the joint doesn't move. So I'm going to drive straight down. I feel my quad and my hamstring. To feel that they're firing, I hold for 3 to 5 seconds, and then relax and repeat. Drive down through the heel. Hold for 3 to 5 seconds, and repeat. This one can be difficult for some at different joint angles. So if I have some aggravation where my knee's bent really tight, maybe I reduce the joint angle a little bit and push in there to get a little more hamstring, a little more quad, so that the knee doesn't aggravate as much. So it's not necessarily what you're doing, but how you do it. So that co-contraction is the basis of a lot of the movements that we do, squatting, stepping up, lunging. So that's where we start everything to get those shock absorbers. Right. So we're going to use that same idea when we pull this band out. So this is just a piece of what we call TheraBand. It's tied a knot into it. You can also buy things called mini bands that are a complete loop from a store or from online. And this is going to go around our ankles, and we're going to work our glutes. So stabilizing our glutes to stabilize the knee is huge. So if we're going to put this on, we step into it. I always say, try your best not to fall over. And I throw it around the ankles. So now I'm working the side of my glute here. So this is what we call the glute medius. We take that bent knee athletic stance. I'm going to focus on heel pressure. Meanwhile, I'm co-contracting the thigh here. The quad and the hamstring are working together. I'm going to push into the ground to stretch the band. So I'm going to take a couple steps right, a couple steps left. Hands on hips to stabilize the upper body. So I step, guide, step, guide. Heels are the focus, stepping back and forth. On this, just as I mentioned during the co-contraction, I can play with the joint angle. So I can stand a little taller if down deep is aggravating to my knee. Stand a little taller, emphasize the heel more, step side to side. Big focus, toes straight forward, level shoulders as I step side to side. This co-contraction, not only at the quad and hamstring level, but now we're talking up into the hip. So the hip's being nice and stabilized. And the more strength I can have at this hip, the less motion we're going to have at the knee. And if I stabilize here, the knee's going to be less aggravated. Very good move for that. Really good point, yeah. So stepping out of this band, and again, these resistance bands, this is a green level. We can move up or down resistance levels depending on the brand. The colors indicate the resistance level.
Tensile strength, yeah.
Last exercise for our knee OA, we're going to go down to the ground for this. We're going to do some hip bridging. Again, that same principle of co-contraction is going to be the key here. Heel's going to be my pressure. I'm going to push down and co-contract the quad and the hamstring, and I'm going to raise the hips up and squeeze the glute. So get that neck flat, back flat on the ground, drive through the heels, raise the hips up, squeezing. I'm firing all through here. Lower down under control. So it's that raise up, drive through, hip extend, straight line from my shoulder up to my knee, that angled down towards the floor, then lower back down. This is also a great exercise for hip arthritis, for low back pain. This is a very beneficial exercise for more than just the knee arthritis. It's a very awesome thing to utilize.
My uncle and godfather had 2 knees replaced.
Right.
The first one he had done at 60, and he was supposed to have them both done at the same time. And he had a great result from the one he had done it when he was 60. Well, he waited for the other one, because it's a long road, and he got the other one done at like 75 or 6. And his surgeon had retired by that time. And when he got it done, he wasn't nearly as happy with the second one as he was the first one. And he kept on saying, I should have gone with the first guy. He knew what he was doing. And I said, Uncle Tony, I said, the reason you had a worse outcome for the second one is because you weren't doing the rehab that you were supposed to.
Interesting.
It's so important, the rehab for a knee replacement.
It's huge. And people that have them done will tell you that. And like you say, the patient oftentimes will tell you what they need, and they'll say, you got to work it, you got to use it, you got to do it. And whether you've had surgery or you go a non-operative route,
non-surgical route.
You need that.
After 25 years of medicine, I'm basically just reiterating what my patients have told me for 25 years. I should be paying them, and I was kidding about that.
Yeah. Don't quote me. Right? Yeah.
So the second one would be the rotator cuff impingement. So this one I don't think maybe is kind of intuitively understood. So explain to me what you mean by a rotator cuff impingement.
With the lack of a model to show, the rotator cuff, people that get this rotator cuff injury are generally people that are working overhead. So your overhead throwers in sports, so baseball pitchers, softball players, volleyball athletes, in the world of carpentry, stuff like that. Somebody's working overhead. I know I've got some athletes that come, they were painting their ceiling for a long time, and all of a sudden they got a flare up in their shoulder. Mm-hmm. So what's going on is in the shoulder there is the rotator cuff tendon, the supraspinatus tendon, that will run right around here, and there's a spot right there called the acromion. And so when that space, the humeral head, so the ball in the socket, will sit up a little bit high and pinch that space. So a classic symptom for this rotator cuff impingement is you're sleeping, lying on your shoulder, and it wakes you up out of a sound sleep. It's a very achy, painful thing, and it'll wake you right up.
Especially at night.
It's a classic thing. So what we do for therapeutic exercise for it is try to reset that shoulder, that ball in the socket, by using the rotator cuff muscles, your lats, all your scapular musculature, to help set that ball and socket into a better place.
Into a proper position.
Yeah, that's the idea.
And that's so often what we're trying to do with physiotherapy is just kind of restore like a healthy anatomy and function to a joint.
Right. Moving forward, looking at the rotator cuff impingement. So a couple things need to happen here to reduce that. As we talked about, that ball and socket idea, if it's sitting kind of high, we want it to settle down in and get that same idea of co-contraction.
Right.
So we're going to do a couple strengthening exercises, and we're going to do one stretch, an internal rotation stretch, to help create that space. So I'm going to ask you to help me out. Awesome. Thanks, Peter. So we're going to have you stand right there, create a little tension. Now, if you don't have a close personal friend like Dr. Hogenkamp, you can tie this off to a doorknob, to a banister, newel post, whatever you have in the house that can help be a nice sturdy post. So in this demonstration, I'm going to demonstrate 2 different shoulders. So this one, I'm working my left shoulder. So my start position is neutral, all right? I'll give you a little demo here of what neutral is. We look at this rounded. Often people will say that's the slouched posture. Everybody has that slouched posture. That's where we live right now. There's extremely way back, and then there's neutral. We want to sit in that neutral posture with all these exercises. So I'm going to stand tall. The first move we call external rotation. Elbow nice and tight to the side, level shoulders, and hold tight. Hold tight. All right. I'm going to rotate out and then guide back in. Farther is not necessarily better. I want to pull it out under control, guide it back in under control. There's never a quick, sharp in or out. It's smooth out, smooth back, creating that good co-contraction. So that's our external rotation. Now I'm going to switch shoulders for camera purposes and show you the internal rotation, so pulling in towards the body with the hand, with the right arm. So same idea, neutral posture, elbows tight to the side, pull in towards my belly button, and then guide back out. Pull in towards that belly button, guide back out. And the start point where you go is going to be a little bit different for each person, but go to a comfortable spot, kind of where your arms would almost naturally sit. Start in that position, and then work in and out from there. Really, really cool exercise. Now, the rotator cuff muscles are what we were trying to work there. Now we want to work the scapular muscles. Working the back, the upper back, these lats and rhomboids, very important for stabilizing the whole shoulder. So I'm going to switch this position for you. I'm going to take both sides. You grab the middle, and this one's a little bit easier. This is the one you can really loop around a post or whatever. And now I'm going to row. This is going to be starting with straight arms, and it's going to be about the back, right? It's going to look like it's about the arms, but it's about the back pinching and then returning. So the keys here are stay down and back with the shoulders. Down first, back second. So I'm down low, pull shoulders back. And I'll give you a little key that most people do on this one is to shrug up. Calm and shrug up, right? Whether it's stress in your life, lifting heavy things, all that sort of stuff. We like to shrug and go into this trap position. I want to, boom, keep you nice and low so that everything gets down out of that impinged position. So there's 3 exercises right there: external rotation, internal rotation, and scapular row to help set that shoulder in a good position. The last piece for that one, and so let me give you a couple reps and sets on that. 3 sets of 10 to 12, very good. You can spread it out throughout the day, or you can do it all kind of right in 3 sets right there. The last one that we find to be very beneficial for this is the stretch, a towel stretch. So this is your standard towel. You can use a bath towel, you can use a dog leash, whatever works for you. I'm going to demonstrate the stretch on the right shoulder. So I'm going to throw this over my left shoulder, to grab with my right arm. And so that same holding, good posture, I'm going to pull down with the right arm to get the left arm to go up my back. I'm going to hold for about 15 to 20 seconds. I'll release it and repeat it. Pull down with the right to let the left come up the back. This one's a great one to do. It's very convenient to do, especially if you're getting out of the shower, right? You're toweling off anyway. Let the moist heat water run on the shoulder. Let that feel nice and good. You're nice and warmed up and ready to go. And then we put the stretch on it and relax. So it's something that can be kind of built into your day already.
Right, that's what I like about that. It's like you have a memory. Listen, this is a prompt for you. So the third one, near and dear to my heart, would be the tennis elbow.
Yes.
And this is so common. You know, I see this as a primary care doctor. And it's so often that people don't play tennis.
Yeah, almost never. Yeah.
Right. So the issue is lateral epicondylitis. So tell us, so what that is, who gets it, and how they would present.
So it's the degeneration of the extensor tendons in your elbow. So everything with your wrist that straightens or extends your wrist causes that breakdown of the tissue. So Dr. Gammons, a good colleague of mine, will describe it like a frayed rope, right? So if you give good strong tendon on evaluation, it looks like a strong rope. The frayed rope is that tendinosis, that lateral epicondylitis.
And he can actually see that on ultrasound.
On diagnostic ultrasound,
Yeah.
he can see that frayed rope.
That's what mine looked like.
Yeah, that little extra frayed rope. So what's happening there? So it's a broken down tendon, oftentimes from either gripping things too hard for too long. The reason it was tennis elbow was back before the two-hand backhand became so popular in tennis. A lot of people were one-hand backhand,
Right.
and so that works that extensor. That's where the tennis elbow comes from. But
Right.
a lot of people that, again, those people that are grasping a lot or holding on to things will get that. My father had it. He's a mailman. He was delivering mail and sorting mail.
Nice.
Constant load on that. So
Right.
that's the people that will see it. It presents with that achy. It's like a toothache in the elbow. It's just very, very painful and aggravating.
I couldn't hold a coffee cup.
Was it to that
Yeah.
level for you?
Yeah.
It can become debilitating to people. And what I find with people that I'm working on their shoulders, rehabbing their shoulders and such, they have trouble gripping the handle or the band that they're trying to work with. Mm-hmm. So it can help, fixing one problem can help solve another
So
problem.
how do you solve that problem with, or treat that problem with exercise?
So we use eccentric loading. So eccentric loading, I will give you the basic description of that. Concentric, for contraction of the muscles, is, if we're using my bicep as an example, pulling up. It's the shortening of the muscle. Eccentric is the lowering down. Tendons, through research, we find that tendons deal better, handle eccentric loads better. They like that lowering motion. And so with that, we're going to work on holding a weight and lowering down, and that will put stress. It's good stress. It actually hurts when you do it.
Right.
We will tell
You can
people
feel it,
we
yeah.
want this to hurt a little bit so that it'll help you in the long run. So we're breaking down a little bit more of the tissue so it will help heal it in the long run, because we end up, the inflammation, the aggravation is actually a way of helping the body heal itself, but under good load, eccentric load. So we're going to grab a dumbbell for the tennis elbow. This is that key factor of eccentrics again, all right? So if you don't have a small dumbbell, this is a 3-pound weight. If you don't have a small dumbbell, we use a hammer or a soup can or something like that. That can help you increase the load into the tendon. So with a straight elbow, arm braced on a table, nice straight arm. Start with your wrist up without the weight in it. We throw the weight into the hand, and slowly 4, 3, 2, 1, let it lower down under control. That's that eccentric loading on that tendon. Now, we don't want the concentric because that can be aggravating.
Right.
We take the dumbbell out of the hand, raise it up without weight, throw it back in for rep 2. So each rep is 4, 3, 2, 1, that 5-second eccentric lower, take it out, raise it back up. And so that key, that tendon likes that eccentric load, so we want to give it that smooth, lower down, under control. And same idea, never too hard, never too quick. I want it to be smooth as possible when we do that. That's exercise number 1. Strength exercise number 2 is going to be an isometric hold. And so isometric is the muscle firing, the joint doesn't move. So I'm going to use my opposite hand, I'll even do it braced here. I'm going to push up into my opposite arm. Again, working the right arm. I'm going to push up into my left arm. I hold 3, 2, 1, that 5-second hold, and then relax. And again, push in, isometric, hold, 3, 2, 1, then relax. That's that same idea. That's almost like the co-contraction idea,
right,
more than the eccentric lowering. So the key with that one is, again, never on too quick, never off too quick. We're going to cause aggravation with that.
Easy on, easy off.
Easy on, easy off. Very key for that one. And then the 2 stretches for this exercise or for this condition is going to be a flexion stretch, where I'm just going to grab the back side of my knuckles with my opposite arm, hold the elbow straight, push down in. Yeah. And now this one, if you've had the tennis elbow, you're going to feel it. All these are going to be a little bit painful. I like to tell people, don't baby it, but don't kill yourself.
Right, and that's the exercise that I use to keep my tennis elbow away.
This is what you consistently do this one?
I always do it all the time.
It's an awesome, and it's simple.
It's
right?
simple.
And it's almost natural.
It is natural.
Right, you naturally say, oh, that hurts a little bit, let me push into that. Right. And it's a great stretch to do.
I've come to kind of like that little painful sensation because I know I'm stretching it out, and honestly, I probably do them 3 or 4 times a week, and it just keeps away from troubles.
That's a great point. You may not, once you get the pain and the aggravation to settle down a little bit, you don't have to do it every day anymore. Maybe just 2 or 3 times a week, and it can settle things.
You know what makes me think of doing it?
What's that?
When one of my patients comes in with a problem. I'll show them the exercise, and I'm like, oh yeah, this has been bothering me. Here we go.
I've forgotten about these. Yeah, it's very important to have. So those are the simple exercises for that tennis elbow.
All right, and so lastly, the Achilles tendinosis. This is another common problem. And most people know where the Achilles tendon is, but
correct.
But what is the tendinosis we're speaking of?
So it's that same idea, right? It's a tendon. So a tendon issue like your elbow, like your tennis elbow, is going to be the same tendon issue in that Achilles tendinosis. And it's those jumpers, runners will get this tendinosis. So it's still that breakdown, that frayed rope of the Achilles tendon. That's what's happening there. And the treatment for that is the same idea as the tennis elbow, just with a little different exercises. The Achilles is one that, both with the Achilles and the tennis elbow, both of these, there's going to be aggravation involved with the exercise. Oftentimes it's don't hurt it because I want it to get better. These tendon issues, we need to let them have a little bit of pain because the regrowth of the tendon is what's going to help us. So a little bit of pain is expected here. So any of these exercises, remember this. So I'm going to take these little blocks here, and we're going to do some what we call eccentric loading on this as well. So having the block set up, I'm going to use both feet to stand up. So I'm going to go straight knees. I'm going to raise up using the ball or the arch of the foot, the ball of the foot. I raise up, and I'm going to shift over. I'm demonstrating my left leg here. Shift over to left,
Single leg, lower, 3, 2, 1, down below the level of the block. Put the other one down to aid in that up motion.
Right.
And then shift over, lower down, single leg, 3, 2, 1. That nice, slow, smooth. And then use the other one to help it back up. Again, that same idea of helping up with the opposite is there so that I'm not just concentrically
And you're balancing
loading.
on the table so that you don't fall when you're
This
on
one
the one
is,
leg.
it's not a balance exercise, it's a
Right.
strength exercise,
Right.
right? Some people will go, oh, well, like you're cheating.
Right.
That's not cheating. We're trying to aid the exercise.
Yeah, I'm also
So-
not trying to fall over.
I'm not trying to fall over, right? So that being done, but also with a bent knee. So I did a straight knee on the first one. I'm going to do a bent knee movement on the second one. So I'm up with 2, shift, down with 1. That 3 to 5 second lower. Then back up with 2, shift over, smooth, slow, down with 1. That's a great eccentric load on it. The last thing is a stretch. So the stretch on the Achilles, I love this one. It's simple. My back leg's going to be the one I'm stretching here. Again, I use a table or a chair, something to keep that heel down and keep me balanced. Straight knee for 1. I'm going to lean forward and feel the length through the backside. Now, this is more of a calf stretch than an Achilles stretch. So I feel that length right there. Hold that for 15 to 20 seconds. And relax. Repeat that 3 to 5 times. The second stretch is a bent knee stretch. So I'm going to bend the knee, then shift the hips forward. Flat foot, everything, toes, knees, hips, everything's pointed straight forward. I hold that for 15 to 20 seconds and release under control. Those are the strength exercises and the stretches that will help reduce this aggravation of the Achilles tendinosis.
Hey, Tyler, that was phenomenal. Want to thank you very much for showing up today and helping us out. I've actually learned quite a bit, which is why I love doing this show.
Glad to hear it.
Thanks again for the folks at PEG TV, and tune in again next month. Cheers.